Okay, well, thank you everybody, and thanks for your patience. We're a few minutes late. My name is Paul Baker, and I'm part of the group that's organised and hosting this event this evening, and we are the Taking Control of Psychiatric Medication group based in Greater Manchester, coming out of Hume, which is in the inner city, and we're based at a radical community arts centre, not mental health. And we do lots of good things there. And one of the groups we have is this group. We were very fortunate to receive a small amount of money from the National Survivors and Youth Survivors and Users Network, based in the UK. And and because of that, we were able to pay for a really good Zoom account, which allows us to hold these meetings. So this is the third in a series of our Zoom meetings that we've been running since early summer. And in the past, you may have been to our last event where we had Joanna Moncrief, who's a psychiatrist from the UK, who talked about her perspective on what is known about medication from a critical psychiatric perspective. And you can now find, if you missed that, you can find that on YouTube. You'll find it at a number of different places, but if you go onto YouTube and just put in Joanna Moncrief's name, it will come up. But we may actually just put it in the chat for people, so you can visit that if you wish to. Right, so we also had a meeting where we had Dirk Korstens and Alison Beninsky, who looked at it from the perspective of a psychiatrist and somebody who's actually removed medication from their lives. And so you see there's various themes that we've looked at. And today we wanted to discuss an issue which is close to all of our hearts, really, and that's the role that medication plays in our lives, and trying to get an understanding of how we gain the maximum autonomy we can in relationship to that experience. And we're very fortunate today to have with us Celine Cyr and Olga Runciman, who are our two guest presenters, who will be having a conversation with each other about their own lived experience and also their knowledge and work experience of talking and knowing in depth about this issue. Probably two of the best experts in the world we've got with us today, I would say, and I'm not kidding at all. Before we do that, though, I just wanted to go quickly around the room to let people introduce themselves to you, just to let you know how the meeting's going to run. We're going to have Celine and Olga having a conversation, and then the panel, there's about 1, 2, 3, 4, 5, 6, 7, 8 of us outside, 7 or 8 of us who will be asking questions and having a discussion with our two speakers. And this is part of a thing that we've been doing for 3 meetings, where the same group of people and some guests have come in, and we're learning ourselves about this issue. So this is part of our process. But then there will be plenty of time for questions and answers. So we've got a question and answer setting on this Zoom, so you can put your questions in there, and there will be lots of time to deal with the issues that will be coming up during this meeting. So that's me, and I'm just going to say, Neil, could you just introduce yourself?
Yeah, my name's Neil Caton. I'm near Manchester in the northwest of England. I've got lived experience, or I do take medication at the minute, an antipsychotic and antidepressant, and I hope one day to come off them. I guess some housekeeping just to start with as well. If you, Paul just alluded to it before, but if you've got any questions, put it in the Q&A section, not the chat. And feel free to use the chat for anything else, but be aware of who you're sending it out to, because I think there are different functions allowing you to send it to different people. So just be aware of that. Yeah.
I'm Jake. I'm from the Greater Manchester area as well. I've lived experience of complex post-traumatic stress disorder. I take an SSRI, have done for a number of years, and yeah, have had not a very good experience with it, and not a very bad experience with it. It's just been a kind of neutral experience, I guess. So yeah, thank you.
I'm the parent of someone, I've got an adult child who's in psychiatric services at the moment, and I'm also a member of CHARM, an organisation that a number of us have recently set up, which is a community for a holistic, accessible and right-based mental health in Manchester.
Oh, hi. Do you want to go first, Tom? Yeah.
Yeah. When I had my Kundalini awakening, it was very powerful. And I doubted reality for my previous reality had changed in some respects. So after my awakening, spiritual awakening, I had a lot of energy. I felt like I could fly almost. And I was flying in Sheffield. Yeah. Mine's Thomas. I was doing philosophy at Sheffield when I first had a Kundalini awakening. I felt like I had special powers to fly, etc.
Say anything about
yeah, I'm opposite you now.
Yeah, and my name's Jen, and I'm Tom's mum, and we're working towards with the psychiatrist to start reducing Tom's medication. We've had a discussion, and we're going to be working on a plan soon, but we're going to do it very carefully. And can I just introduce Kenai, who works with Tom?
Hi, I'm a support worker. I've been working in the mental health for about 10 years. And my brother had problems, the same mental health. He was sectioned for like 2 years, and basically he's improving as well because he's on medication which he's reducing himself. And it's an ongoing process. And I'm along with you guys with everybody should have the freedom and right to make their own choices, you know what I mean? But it's like I said, I'm with all you guys, and I'm being positive regarding it.
Thank you, Kenai. Yeah.
Hi, welcome everybody. I'm Rita from Greater Manchester, UK. I've had quite a rocky journey with psychiatric meds, and my passion here is about starting something in the UK where people can actually access proper information, support, and guidance, particularly from a peer perspective, because I think my journey has been quite a lonely one, and I'd like to sort of use that experience really to support people to get access which will support them in the way that they want to be supported.
With that note, can I just hand over now to Celine and Olga? Would you like to make some opening statements about where you're coming from? And perhaps we could start with Celine first.
So I'm Celine Cyr. I am a prosumer, so I have lived experience, and I'm also a social worker. I try to empower myself and the people I'm with regards to psychiatric medication, or with different approaches. I'm very much, I have a conflicted, tense relationship with the biomedical model. I think I would call it the biopharmaceutical model, because a lot of what we know and hear is from the pharmaceutical companies. So my way of not staying too angry too long, because it's not good, especially when you age, is to develop practices with my peers. So that's what I humbly try to do. And I'm one of the GAM pioneers gaining autonomy and medication. And I find I was very fortunate when I was young to experience a group where we developed something that now is going around the world. So very young, I got the experience that I could change something, but not by myself, with others. So I'm really happy to be with you, with Olga, the rest of you. And if you see my head twisting to the left, it's because the roofers just got on my roof, and I'm afraid they're gonna fall off the ladder. So I'm checking. Won't make any differences, but I'm still checking. All right, thank you.
And hi, my name's Olga. I live in Denmark, in Copenhagen. I have lived experience as well. In fact, many years I was lost in the psychiatric. I say lost in there, felt lost, completely given up upon, and I've tried a numerous number of drugs and been on them for many years. I am now off all drugs and have been for a long, long time. I am a voice hearer, so and I'm the chair of the Danish Hearing Voices Network. I've also been part of the organization, or part of the group that started the International Institute for Psychiatric Drug Withdrawal. Today I used to work as a psychiatric nurse, and then I became a patient in the same system, which I always say was the place I learned the very, very, very most. Amazing. I wouldn't say I don't recommend it, but that's where I certainly learned the most. So, yeah, so today I'm actually a psychologist. One of the things I wanted very much when I was lost in the psychiatric system was to talk about my experiences, and I was always told as a schizophrenic that wouldn't be good for me. It was best to just leave things as they were and just, you know, take life easy and etc. And that it would actually also be bad for me. So one of my things was when I found a way out, I decided to become a psychologist for all those who were told that they should never get any help therapeutically if they didn't want it. So that's what I do. Today I work a lot with helping people off their psychiatric drugs. I see that one of the things that being part of this institute is that there is now a huge interest and a developing interest in how the drugs work and how, you know, the getting off them and that sort of thing. But there are very few people who are working down on the ground, helping people off their drugs. So that's one of the things I do, done it for a long time. So I have a lot of practical knowledge and things that I know work if you can combine these mechanisms together. Yeah, so that's sort of where I am. I'm an activist. I'm actually, yes, very critical of the biomedical model. I'm also very critical of psychiatric drugs. And that's not to say, you know, I truly believe in choice, but what I do see is that a lot of people, it's not usually a problem to get the drugs and to want the drugs, if you know what I mean. It's actually all the people who don't want it. So I'm very much an activist for that group of people. And another one is access to knowledge. People do not have access to knowledge. I think that is really very, very bad. You know, the myths, stories, and direct lies about how psychiatric drugs is still very much rampant. So that's kind of a little bit where I'm at. Yeah.
I would bounce off on some of the stuff you've just said. If I were to say what is my stance, you know, towards medication, it's very much like Olga. So I am not against, you know, psychiatric medication. However, I see the limits, and I'm very aware of the potential damage, especially of certain classes of medication. So if I would say what I'm against that, I would say there are two things in the move. Well, with regards to treatment, polypharmacy. I mean, giving 3-4 neuroleptics to somebody, 2 mood stabilizers, 2 antidepressants, too many meds. I mean, that doesn't make sense. So that I'm against. However, if the person is informed and agrees to that, that's his or her choice. But I would keep coming back at it. What I'm really against, because I'm an activist too, is ECT, electroshock. So I'm part of started a committee with others about 15 years ago. There are many English voices against ECT, but in French, to my knowledge, it's been the only voice. And what I find, maybe I'll say where I'm at right now with medication, in the sense that I do stuff like you, Olga. I I accompany people when they're reducing their meds. I also do follow-up, because often the people I meet in groups, in individual follow-ups, they are ambivalent, they're confused. So GAM helps them, you know, having a safe space of open dialogue helps them to sort out things. From my end, I also see that it's a process, and like any process of empowerment, there are different steps to it. And the thing that I think about a lot on a daily basis, actually, I'm for empowerment, free choice, and I want people to have the information, but sometimes the information, people are not ready for it. They're scared of it. I'll give you one concrete example. I think I'm really diving into a very concrete issue, and you can respond if you wish, Olga. I'll give you one example. Many people, especially women at the organization that I work at, have been on lithium 20, 25 years, okay? So we have people now that are going on dialysis, that are being, that are waiting for kidney transplant, being tested and all that. What do I do with this? I'm very upset by it. I'm very saddened by it, because even though we have GAM, we have a safe space of open dialogue, people may not be, some people are not at the point of looking at the impact of long-term medication. So I'm really struggling with many things, but I'm really struggling with that. This is where I'm at on one of the issues.
It's really very if I was to bounce off yours, is the long-term consequences, which people don't know about and they don't have access to, and also it's very scary if you have access to it, like the early deaths, I could be really pessimistic. I don't know about, we've done a big study here in Denmark regarding, for example, young people with the diagnosis of schizophrenia, looking at from the 18 to 30-year-olds, for every one person who passed away in the normal population, 14.3 were dying in the long-term institutions and 13.9 in the hospitals. Now, this included suicide and all kinds of things, but these are incredibly high numbers. This is young people, and then you have that the average, the early death rates of around 50, between 50, 55. These things are appalling, and people are not informed of it. And originally the psychiatric drugs were meant as a sort of a short-term thing, but they've become lifelong for most people. So you've got that aspect, which of course is very scary if you're stuck on psychiatric drugs and thinking, oh, what to do, because society and especially psychiatry is pushing a narrative of it'll be really, really bad if you stop your drugs. And, there's also another complete false narrative that's called that if you have, the more psychotic episodes you have, the more brain damaged you are. That is a complete fiction. There is no evidence for that. But on the contrary, we can have it with psychiatric long-term use of psychiatric drugs. I think Johanna Moncrief was mentioning it the last time, is that you can get drug-induced psychosis. So, it's kind of like saying if you fall in love 10 times, you're going to be brain damaged. I mean, our brains are meant to be active, and this. So there's many aspects of that. So I always think of psychiatric drugs. I kind of compare it a little bit to smoking. In the olden days, and certainly in my youth, cigarette smoking was really in. The advertising was massive. It was fabulous. There was nothing wrong. Basically you were an oddball if you didn't smoke. And then it started to creep in that it was dangerous. It had bad effects. It could cause lung cancer and stuff like that. And there was a huge fight to hide that. Finally, they couldn't hide it anymore. And then for a short period, we had a time where it was said that passive smoking was okay. That didn't last long. Today, everyone has access to that knowledge and people can choose. And I think this is one of the biggest things that we need to have access, because psychiatric drugs, they create an imbalance. They do not correct an imbalance. And some people will experience that imbalance as helpful. And they should be allowed to, I mean, you know, that's people's choice. It's not going to fix anything. It's not going to rebalance or anything, but the imbalance it causes is helpful for some people, but for a lot of people, they don't want it. And these people need to have a choices to choose different kinds of help, different, you know, we need to, at the moment, psychiatry is the dominating establishment system, especially in the Western world, and they're allowed to have forced customers. Imagine the day it was on the free market and we had a collection of possibilities and they were not allowed to have forced customers anymore. What would happen? What kind of interesting situation would we have if there was a real choice of possibilities, from open dialogue to nature to, I mean, to whatever? That would be something I would really, really love to see. So I'm kind of thinking of those along those lines. Yeah. Wondering what you're thinking, Celine. Yeah.
I'm thinking about 50 different things at the same time. I don't know if there's a medication for that. But yes, there is actually. Medication slows down thinking processes. And I'm thinking, how do we, the medical discourse is, as you were saying, is, you know, is false, but people believe in it. Okay, most people. So how do we go about bringing about the fact that it does not create, you know, it does not fix a chemical imbalance, et cetera, et cetera? How do we bring about to the larger, I mean, let's start with our own organizations. I think we have plenty of work there. But how do we bring it into the open that medication does not fix the brain? It can be helpful for some, but for some people, it's not helpful. And for a percentage of the people, it makes them worse. You know, the medication do not heal. Okay, so how do we? The medication has limits. It will not. It will not take care of all your problems. It will not eliminate all the suffering. And I'm basing that on my own experience, but also on the narratives of people who took those medication. So I think one way is to hear the voice of the medication takers. So I think so. Yeah. So how do we dismantle this paradigm? It's a big job. It's a big job because it influences, you know, the choices people have access to in our society. Because the main choice, the main offering for suffering is psychiatric medication or ECT. So we need to widen this in our society. And yeah, what are your thoughts on that, Olga?
One of the things I think also is that we are living in an era of the quick fix, you know, and we're also living in an era that's, you know, we want to eliminate suffering, where actually suffering is part of the human condition. It is normal for us to grieve when we lose the person we love. It's normal for us to have all these reactions, and yet we try to avoid them. So we have a culture, or you know, of the quick this quick fix. We also have a very individualized, in many countries anyway, are going for the individualized way of being, and I think that isolates. So this is a bad combination, sort of, if I'm looking overall at society. And I was also thinking, you know, so I think that one of the most important thing is to bring back that it's normal to suffer, you know, as it is normal to experience joy and things, because psychiatric drugs supposed to help with the bad things, the bad feelings, but they actually also remove all the good things. And I spent, I mean, you know, anyway, that's another part is how one experiences it. But it makes me also think of our voices have had great difficulties ever being a part of the dialogue. For example, when I wrote my thesis, I decided to look at the literature from 1950 to the end of 2000, I think it was, or 2000 and I can't remember, 2000 something, doesn't matter, where I was looking at all the research on the experience of psychiatric drugs as from the I was looking at more from the point of view from as a schizophrenic. And what was fascinating, but also extremely tragic, is that there is been virtually no interest whatsoever in the research from the voices of those who are taking the drugs. It is all top down. So the whole description and narrative about how psychiatric drugs work is top down. So our voices have not been a part of this. And this is something that our voices have always been there. It's always been there, but there's been many mechanisms in place to you know, make that voice, to silence that voice. It's either the voice of the mad or the all kinds of narratives to just basically silence. So I think that those are the sort of things that are really, really very, very powerful. So that needs to come out to be an acknowledged point of view. And then also, I think very interestingly, in terms of getting off psychiatric drugs, there's this huge interest now being part of the Institute. It's very, very interesting to follow that there's this surge from the professionals, but actually the knowledge that we're digging out is knowledge that has been ours and has been developed ever since the psychiatric drugs came onto the market from the middle of the 50s and onwards. So there's a huge body of knowledge that is created by us, by our voices, that is now being taken up and used. And I'm very I really want to make sure that again our voices do not disappear in this history of the experience and all the information on how to get off the drugs in a good way, because that is so far this comes from us. There's only just now that this interest is occurring in the professional psychiatric and psychological fields. So those were some of the, again, many thoughts. I could go on.
Okay, so I'll bounce back on some of the things you said. The suffering, suffering is part of being human. And so what I say, and I try to believe it for myself, but when I'm not doing well, I start thinking I'm not normal. That's another story. But we're having normal reactions to abnormal situations. So so for me, this should be getting out there more than not just in the movement. Many of us are having reactions to trauma or abuse. So I think it's something maybe our society does not want to hear about the violence. It's really my thesis was on the experience of taking psychiatric medication from the point of view of medication takers, and it was people who undertook a GAN journey. So yes, I agree. There isn't too much research done from our point of view, but at least there is some. In the last 10 years, you have to dig for it. Mine is available, but it's in French. So maybe one day I'll make it available in English. And the other thing is that I do GAM groups. So when I do a GAM group, it's anybody that has questions about medication who are or who were medication takers. And often I have a large percentage of the people in the group are people that are reducing or trying or thinking about reducing. Because where I come from, the longer you stay in the system, the more meds you take. You know, there is this relationship. Especially if you have had a hospitalizations, you know, you increase the medication more and more, and they leave it at the crisis level. Sometimes they do bring it down. So I am so like, I took psych meds some years ago. It was mostly antidepressants. And so I don't have the experience of reducing from long-term neuroleptics, for instance. And thank God, there is the expertise of the medication, of the users. And it's them that are helping each other and have the information. They're incredible. So this stuff should be getting out there. And people who undertake a GAM journey, nothing bad happens. There's this myth that if we question or take less meds, something really horrible is going to happen. It can happen. You can go back to the hospital, but that's usually not the experience. Usually not the experience. So that's what I would say on what you were saying.
So I'm curious. You're saying GAM journey. What can you? What is that?
A GAM journey. I can send you the book. We have a lot of literature, and it's translated into English. A GAM journey is looking at your life at the moment in the different spheres of your life, in a group, by yourself, or in an individual follow-up, to see how your life is now. So it could be about your daily living, your living conditions, your relationships, and afterwards you look at the impact of medication on the different spheres of your lives. So this is a way of looking at the quality of life and the impact of medication on your life. It's very straightforward. It's common sense, but in psychiatry, we lose common sense, you know? So the goal of GAM is that if you're taking medication, it should be improving your quality of life. It should not be making it worse. So after you've looked at your life, then you're in a better position to make up your mind and decide on the impact of medication and if you want to bring changes to your medication or not. And it's really a step-by-step process. I'm part of the alternative movement in Quebec, and it's a distinct movement because we are French and a lot of people don't speak English, so it's an alternative movement. And so GAM is part of these alternative organizations. If you want to be part of the coalition of alternative organizations, you have to adopt GAM or to agree to want to develop GAM into your organization. So this is really, in a nutshell, very quickly.
Thank you. No, I was just wondering. Also, I was thinking there's probably other people wondering what it was. Yeah. So, it actually makes me think of Robert Whittaker and his book Anatomy of an Epidemic, which was, I think, was really also a brilliant book. Asking the question, if psychiatric drugs are so helpful, how come people are becoming more and more handicapped and basically going on to I don't know what you call it in English. We call them psychiatric pensions and things, which, for example, I was on the absolute highest one we have in Denmark because I was considered incapable of having even the most microscopic of jobs or anything really. you know, so and then I also think of open dialogue. That's always made sense to me. So I was very lucky to be able to come actually to the UK for 3 years, backwards and forwards, and take the first Finnish run open dialogue in English. But for me, I'm thinking in that area, you have by far the best results in the whole entire world on how to help people in severe distress. And basically in that area, you don't really have schizophrenia per se, because people, you know, get better before it's, you know, before the 6 months or so. You know, so I often again think of there you have a roughly 80% chance of, you know, getting better. And that means that you're working or studying or, you know, living your life there. And typically in our Western, you know, Europe, Western, yeah, US, these places, we've got the opposite, about a 20% chance of getting recovering, as we say, you know. And I often think to myself, you know, when I suggest, I sit and say to have a talk or something, and I ask people and I say, you know, isn't it amazing if this was cancer, you know, it could be prostate cancer or breast cancer or something, and you went to your doctor and you said, well, the treatment we can give you will give you about 20% chance of surviving it. And then you say, well, hang on a moment, hang on, over there, they've got a treatment that will give you an 80% chance. I want that. And what does the medical system say? No, sorry, we don't do that. You have to take ours. This would never happen, but it can happen because the voices of those who are subjected to that treatment are silenced alongside it. So, you know, as soon as, and I remember when I was a psychiatric nurse, and then basically from one day to the next, I became a psychiatric nurse to a schizophrenic. And in that moment, the second I trod over that threshold, I lost my voice. Anything I said was seen as crazy or insane or this one. If I happened to agree, then there was some signs of some kind of idea that I had was beginning to perhaps get a bit of insight. And they spent months discussing with me that I had no illness insight. And I mean, I entered a truly Kafkan world that I was working in, and it was extraordinary if it wasn't so dreadful at the same time. And so I spent, you know, this whole, yeah, as I said, I learned an awful lot by being a part of the system that I used to work in. And so there is this weird way also of looking at people that occurs. I remember thinking also about when I started working in psychiatry, how did I lose my common sense as a psychiatric nurse? How did I lose it? You know, because basically, we all know, if you ask anybody on the street, why is Peter feeling bad? Well, they'll usually say, well, probably something's happened to him. But when I became a psychiatric nurse, I had to unlearn that and learn that Peter is mad due to a chemical imbalance in the brain. And what has happened to him is kind of irrelevant. It's a sort of a side effect or a, you know, so very, very strange, very strange. So I can recommend, if anybody wants to try it, to be a patient for a little while. It's the most, you do learn a lot. So I don't know what you're thinking, Celine.
Whoops. Okay. My. We seem to be like sisters in the movement. We've evolved into the same direction. I think a lot of people suffer because a lot of people are hurt. And in our society, Western countries. I'll speak more for mine because I know my country better, but so similar everywhere. I always say there's nothing more similar than psychiatry around the world. Okay, and so a lot of people suffer. A lot of people are hurt, suffer from disadvantages. You know, racism is there, sexism is there, different types of oppression, and our society has adopted the view that it's there's something wrong with the victim. Okay, so and that fits in with mentally ill. I say that, and inside I feel, I'm not even sure how I feel, but I can feel the anger. So things are upside down. It's not the right people that are called crazy. It's the crazy people are the ones who hurt others. So so how can we so anyway, so a lot of people are hurt. The psychiatric system, that's the main offer to people. For me, it's, I'm not saying there's not good people inside. There are good people. I've worked inside. However, the system, the way it's made, the perspective, the view of the person, is not conducive to healing. It's not. I often say that if you are hurting, you have a broken heart from whatever reason, and we put you in a psychiatric ward with 30 other people with broken hearts, little help, little offers, little choices. For me, it's a miracle of life that people come out and heal. So it just, for me, it says something about the power and the healing power of the human soul. So how can we focus on that instead? If you give opportunities and means, people heal. It's a natural process, just like we get a bruise or whatever. It's a natural process of healing as human beings. So how can we organize a system around that? That's what I would say. And I focus more on developing alternatives outside the system, even though I go and teach in the system. It's just that there's so many, there are backlogs of people waiting to go into the psychiatric system. It's a very flourishing business. So I think it's very hard to change it from the inside because they can't even keep up with the demand. So for me, I would love this to be trained in open dialogue, but to be open and develop as many alternative resources and make them accessible. I'm saying, and I'm talking too much. To you, Olga.
I'm going to come in there because we've reached like a 45-minute thing. I thought maybe even more than that, actually. But I thought it might be nice now if we brought the panel in and maybe started having a conversation, if that's all right with our speakers, Olga and Celine. Would that be okay? Thumbs up. Okay, so I would like now to invite in our panel and if you could just indicate to me that you're coming in next. So I've got Jake to begin with.
Hi, I have I've written some things down as you were speaking, and I find I'm in a slightly different situation than perhaps some of the other panelists in respect to the fact that I've never been hospitalized, I've never been on a CTO, I've never had that choice taken away from me, and yet I have been in a position as a result of my own distress and kind of traumatic symptoms that I have actually wanted to take psychiatric meds by choice because to mitigate my own levels of distress. And this has happened even though I've had a therapist in my life. I've had people around me who normalize my suffering, and I know, Olga, you mentioned the importance of normalizing experiences of suffering. I've had that to a degree, and it's been profoundly helpful. And I find that the distress that I've experienced has been so intense, especially over the last year, which is obviously a unique situation for all of us. But I think the question that I have in my mind at the minute, you know, if I just provided some context for it, is when an individual is withdrawing from medication, to what degree is the absence of psychoeducation or available psychotherapeutic support, skills, knowledge about how to handle psychological, emotional phenomena, to what degree does that influence or contribute to a person's, I'm looking for the right word here, well, to them basically going back on the medication? So it's not necessarily a case of, you know, I'm going back on the medication because my schizophrenia has come back or my psychosis has come back, but in actual fact, it's that my emotions are too painful and my memories are too painful and I don't really know what to do about that. So, you know, and I think, you know, from the events we've been on in the past and the conversations we've been present with, I've been present in the past, there's not really much clarity when people do end up going back on medication as to what the real cause is for that. And I just wonder whether actually, you know, skills-based, education-based access to these things, you know, how important is that in people actually having to go back onto their medication?
I don't, you know, there is no one answer to that question. I think it's so individual, but I think if I was just to use how I work, for example, I find that to withdraw from the psychiatric drugs, most people think that that is the most difficult thing, and that is also the thing that's going to change people's lives. Usually if you do it, you know, very slowly and everything, it's, for most people, it's a pretty okay journey across, you know, in general. So, but the things that are required that I've found in my just sort of practical experience is must not be done alone. You need to have the people who are close to you to be on board with that. You need to have something to go towards, you know, to disconnect yourself from psychiatry, but to go towards, you know, the community in some form or manner. And then, of course, also to work with the thing that brought you into contact with psychiatry. And this is can be really very, very painful. And psychiatric drugs, I mean, especially the antipsychotics, are extremely good at putting a big fat lid on emotions, except they remove all emotions, you know, and have lots of other consequences as well. But in that sort of thing, it can make you not care. And this can be, I do think, for some people, really quite tempting, you know, and also to have a break. I personally, if people can, to find strategies along with others, because we cannot do this alone, to find strategies to be in these really hard spaces, and you know, being together and how to deal with memories. Usually they're involved with intense pain or guilt, shame, events that we almost can't bear to look at. Can be so many things, but I think with a good, you know, not being alone, we can do an awful lot together. But then I've also seen people who go back. One of the reasons that I've seen a lot of people go back is because first of all, if you've been in psychiatry for many years, there's also another step, and that's the one, what do you do with all your lost hopes and dreams? This is huge. We don't notice it when you're on your drugs, but when you have access to it, to feeling again, and this, it's you are confronted with things like you can never maybe have children, or your dreams of getting some education or jobs or direction is not possible. You've lost so many things, so there's on top of it a grieving that must be also a part of the healing, which on top of the distress that is waking up, sometimes that's just too much. Okay, so some people decide to shut that door. So I think there can be many, many, many reasons, but if people can stick it and have somebody, it really, for the most part, is worth it, getting your life back and being present 100%, all of
Do you
you.
want to ask a question, Tom?
Yeah, regarding medication, coming off medication, would you suggest that walking in nature is a good therapeutic approach? Walking in nature is a good therapeutic approach when coming off medication? I'm hoping to come off the medication soon. I think I've been told before that grounding is an important part of having a holistic approach to understanding one's mental illness. So
did you say grounding? Did you say grounding?
Yeah, being grounded. So maybe walking in nature is a good way of being grounded. I mean, today, for example, I feel quite tired. My legs. I've been climbing, but really, climbing's an extreme sport. But for being grounded in nature, a holistic approach to really recovering from psychosis.
Okay, so I just want to make sure I understand. So, so if being grounded with nature,
like a cat behind you,
like cats. Okay, what I would say in relation to the withdrawal process, right?
Yeah.
Okay. The people that I see that are, I say GAM journey because where I come from, that's how we call it. It's a period of time where you take stock of your life.
Yeah.
Okay. So it's not just, it's looking to see if you can have less medication. So very much about GAM is that it's a back and forth process. You may start off with wanting no meds, but it's by starting to reduce slowly and having the right conditions.
Right.
Having the right conditions. So people, yes, by focusing on yourself, feeling good, it's a healing process. The reduction, so it could be animals, it could be nature, and taking care of your body, recognizing one of the steps that we have in the GAM is what are your needs, stopping. It seems like a very common sense kind of question, but what do I need now? What do I need to be happy? What I don't want in my life right now? What are my desires, my projects? So often it's as if when we are in the illness kind of mode, it's as if we just survive, and it's as if we don't ask the questions of what do I need to be happy. So to add on to Olga, what she was saying before, one of the crucial step is having a GAM supportive network. If the people around you are all scared and don't want you to question your meds or reduce, I mean, this is not the kind of stress you want. Part of the journey is having just the fact that you are questioning medication, you need a support system. So you need to be able to ask yourself the questions. You need you need a doctor. Some people do it by themselves, but usually medication takers want the doctor to be on board. So one of the greatest force of transformation of bringing GAM is medication takers who introduce GAM to their doctor or psychiatrist.
So could I just say that the question I was going to ask was exactly that, because we've already had meetings and conversations with Tom's psychiatrist about reducing the medication, and we've got an agreement that we're going to start, but I have this feeling that the psychiatrist's plan for doing it could be a lot quicker than we think is safe. So any advice from either of you how we can just gently say to the psychiatrist, could we be a little bit slower, please?
Yes.
How do we say that? Can we say it more nicely than that? How can we do it?
I don't know if you want to go now, Olga, and I can go after, because I want to be fair.
Yeah. Yeah, either of you. That question was to either of you. Yeah. Yeah, good advice.
I think you need to be able to have a safe space. The first thing with the doctor or psychiatrist is to develop a safe space of open dialogue between the patient and between the doctor.
Yeah.
Then negotiation can start if you have that safe space of open dialogue. If it's mostly a paternalistic kind of top-down controlling type of relationship, then you can't, it's as if the expertise and the experience of the patient is not factored in. So you need to have that, and it can happen to develop that. So that could be the first step. And as in Quebec and elsewhere, we have we often practitioners reduce too quickly. Sometimes there is an imperative to do that because the person is having a toxic reaction, but often it's not that what's going on. So most doctors have not been taught how to reduce. They get the information from pharmaceutical companies. So if they don't have access to peers that have done the process, they're not reading the Joanna Moncrief or Olga Runciman, so they don't know. So it could be a place. So we have the 10% rule, and GAM, it could be 5%. You should not go faster than that, because you need the body to adjust, physically. It's a physiological process, but it's also psychological. Just like Olga was saying, the resurgence of emotions that were frozen. So you need time to get readjusted to feeling.
Thank you.
Oh, can I just mention something to Jen, which I remembered from our conversation with Joanna Moncrief, and also a conversation I'd had with a psychiatrist a couple of weeks ago, a psychiatrist that I'm on somewhat personal terms with. So if I start with this particular psychiatrist, what he told me was that there's actually, as long as an individual's not under the Mental Health Act, and even if an individual is under the Mental Health Act, there is room for negotiation about medication, especially if they're not under the Mental Health Act. There is actually quite a degree of power that the individual has about negotiating medication. And one of the conversations me and Paul had recently was about actually understanding the degree of power that we actually have to negotiate, because I think we're not quite sure as service users how much power we actually have to say, I want this and I don't want this, or I would like it done this way and that way. And I also remember Joanna Moncrief saying that I think she actually said that a psychiatrist who's unwilling to have that conversation with you is, she defined it as negligent practice, and actually, find another one. And she said that can be quite a difficult process, but she also said that she's aware of people within her network who perhaps could support an individual who wants to have that conversation and is unable to because the psychiatrist doesn't want to have it. But I think what I have found in my own research is that actually, as service users, we really are entitled to that conversation, and the psychiatrist just has to listen to us. And there is an adherence section of the NICE guidelines which talks of the importance of actually listening to what the patient wants and feel like they need. And so it's something that I think is little understood in the service user world, but gives a great deal of power to those who actually do understand it. So it's, yeah.
Thank you, Jake. Can I just bring in Neil in before you answer those questions? And also, I'm aware that we should be moving on perhaps into the bits where we invite the whole.
Should we go to the actual attendees? What do you think?
Yeah, did you want to ask a question, Neil, or do you want to open up?
I'm all right to go on to the attendees now, I think.
Yeah, anybody else want to ask a question specifically before we move on to the questions from the attendees? Celine, you'd like to say something? And Anandi first.
Yeah, just very quickly, I wanted to ask, in your experience, Olga, what has been a safe rate for the majority of people that you've worked with for reducing medication?
That is such a good question, because one of the things that in the many years is that it varies. There is actually, generally you can do it slowly. I always say slowly. Basically what I say is you start to reduce and give yourself, the long one is 4 to 6 weeks between each reduction. A lot of people use 2 to 3. I have seen people who have, 2 people in my life of many years have done cold turkeys and truly survived, didn't go back into psychiatry. Otherwise, and the one person who was very psychotic, but one of the things we talked about was that if she was willing to let me be her guide, she would ask me all the time, is this a reality or not? And managed to get through the cold turkey that way. Otherwise, we are looking at I have seen people get off within 3 months, and this is many years. Most don't. I've also seen people who are unable to get off it, no matter how much. So it's a matter of getting to the minimum level. But generally, what I would say is that depending on the drug, and they vary also. The general thing is it's become 10%. That's kind of a more professional angle that it's coming also from our own experience. That's a good place to start. I often say if you're on a lot of drugs, you can actually drop very quickly in the beginning and then taper off. The important place is somewhere in the middle is people, if they've been on a lot, they will have an emotional explosion, that when the emotions come back, they tend to come back quite quickly, not a gradual thing. So there has to be a lot of care in that period. That varies also. My experience, now it's beginning to be proven, we can see that, is antidepressants are actually extremely painful to get off. And I have for a long time, this has been before this research, I've always said people should start, my advice has been, start with, if you're on the cocktail or the polypharmacy, which many of the people I meet are on, to start with the antidepressant first, which a lot of people think is, oh, I want to keep that one as kind of a, because you're thinking that's the more harmless one. But actually, to get off the antidepressant, the difficulties can be masked and actually be helped by being on the antipsychotics. So that's been my experience, and I am very, very focused on using the person is the barometer. They know what it's like on the inside and 100% follow them, but their network, the people who are around them, who know them, they are also equally important. They can see some things. So it is that team that I focus on. And then apropos, unfortunately, my years, at least in Denmark, it's very difficult to find psychiatrists and people who will support that. They tend to go too quickly or too slowly. But you have a right. If you're not on any kind of mental health act or anything, everyone has the right. Completely, you choose to go on your drugs and you choose to go down in the rate you want. No psychiatrist can choose that. That is entirely your decision. You have all the rights. But what we have is the power that they have if you go mad, that they can lock you away and force medicate you and use all those human rights abusive practices. And that is very scary. And that's why a lot of people often forget that they, as long as you don't fulfill the criterias, that you have all the rights as anybody else. So I don't know if that was a helpful answer or not.
It's really good. Well, thank you so much for the answer to those panelist questions. I'm now going to move on, if that's okay, to ask Neil if you could just review some of the Q&As. Maybe Rita, you could do it as well, but if you could just kind of go through some of the interesting questions that you'd like to put to all of us, really, but particularly to Olga and to Celine.
Okay, my son is on clozapine and has been since he was 17. He's now 22 years old. He has had 2 psychotic episodes, and this drug has reduced significantly the symptoms of psychosis, so he's more able to function. He did reduce over a period of 3 years, but relapsed into full psychosis, not sure exactly why. How can we work towards a slow reduction without risking increasing relapse? I have read a lot about reduction and remain so concerned about the impact on his physical health. I am really interested to hear about how this could be possible.
I don't know. I can't, of course, say specifically there, but generally my experience is that if people only reduce their drugs, and I'm thinking, there is no other things going on, like how to access, get back to hopes and dreams. If it's a young person who sounds like a young person, I always encourage, what was maybe you had a dream once that, wanted to study or find, go and help other people, or maybe get some kind of job, have a dream of something that connects to society. I think this is really important. So you leave psychiatry. Also, you have to work with the at least that's my experience, is that there's a reason people come into psychiatry, and that reason is going to also wake up when you wake up from reducing the drugs. So something has to be done, some kind of way of being healed in that manner. So for me, getting off the drugs is just one in many ways, for many, actually quite a small step. It is all the other things that are so important that if they're not there, part of that, then you wake up to nothing. You wake up to I don't know how many people who I've known, unfortunately, who wake up to a very lonely life. They have, because you tend to lose your connections, friends, everything like that. Life is very different, and so this part must be addressed in some form or manner, and also so family has to be involved in this if the family's part of it, or friends or something, but not alone. Have to leave. Yeah. So the drugs by themselves is very few people. If it's just that, and life is psychiatry, you can't. It's very difficult. That's been my experience. That's why I have now today, through my practical experience, seen that a package needs to be done. Leave psychiatry, have a network, access dreams, connect, all these kind of things, and work with what was the reason that got you in.
Can I just come in and just say, for the supporters and for the people who are family members or workers who are trying to find another direction for the way that things are going on within the system right now, this is really important. I mean, we in Manchester are trying to evolve and develop the idea of community, and really stepping on the idea that through coming together, we can help restore each other's hope and restore it. And that's partly why we've set this campaign up in Manchester, where we're challenging the kind of idea that we're broken to something else, that something's happened here, and this is a way for us to begin to resolve those issues, and we do that in community. So we're trying to come up with an approach where we really enhance that peer-to-peer space, including workers being invited into that space as peers, where we can begin to learn and share in a different way, lending the ideas and the great historical work of the Satyria network and many other kind of communities which have actually understood that community is essential as a ground-breaking response.
I think one of the questions that I've just read on the question and answer leads on from what Olga and yourself was just saying, Paul, and it comes from a parent who says she really wants to support her son, in coming off his psychiatric meds, but he's really concerned about risk of relapse. And I'm just, you know, listening to what you were saying, Paul, there about your community, about what Olga's saying about your support mechanisms and not living in silos, and having support around you. And I'm just wondering if any of the panel have got any advice or any tips or any experience to share for this parent.
One thing I can say as being a young person who's, you know, had to go through a healing process because of life circumstances and, you know, not through choice. One thing that Olga said just then, which really, you know, hit me quite hard, was when she said, you need to go back into a world where there is some dreams and there's something to live for. And I think, you know, part of me investing in that has been getting involved in this project here. But, you know, the absence of that in my life, I believe for the years before this, caused me major problems, and actually did find exactly what Olga said, you know, that I was healing or trying to heal, struggling with motivation, and found myself, as Olga also said, having lost many connections in the world because of my condition, and felt very lost and directionless, and that I had nothing to move towards. And I struggled for many years with the idea that actually I needed to heal first before I could do that, and actually finding more and more that it's the absence of having that, you know, that joyful life path that's actually made it really difficult for me to heal. It's actually there's been a difficult in motivating myself to be able to do it. And I felt very ashamed about that. And so I think that's a really important thing for a young person. It's definitely been important. I mean, it still is important for me, but, you know, for sure, yeah.
I just wanted to add on to what Jake was saying and Olga, and it corroborates with my experience. The people who decide to undertake a GAM journey, they're questioning medication, and they have been involved in different organizations. They are in part of a community, and they have personal projects. Often the trigger to question medication is because they want to do something and the medication is stopping them from helping, from doing that. For instance, somebody may want to do something, they have to get up early, but the medication makes them feel sleepy in the morning. So yeah, I think that's probably why it's working well in my organization and the others, because they're not alone. They're not alone, and some are involved in art, some are teaching, some are in the process of going back to school, some are starting a family. So they are connected and with themselves, engage in projects and dreams, and with the community. Yeah.
Paul, there's quite an interesting question, if I could just draw attention to it, by Danielle Bailey, about the parental impact of taking medication. So this is obviously for children and people in CAMS services. I work in CAMS, and a lot of the young people we work with are pushed to be given medication by parents who lack understanding knowledge about alternative treatment and are focused on the quick fix, often with the best intentions. Sadly, this seems to be the focus despite offers of talking therapies. I think mainly because they perceive that medication will fix these experiences for the young people without addressing any of the other factors in the systems that have and continue to impact on their child or young person's life. The difficulty is often that these young people are exposed to medication from a young age and can often be on these different medications for a long period of time. I wonder if more focus was given to informing parents about these alternatives and hearing the lived experience of adults who have been on medication for such a long time may offer them a point to reflect on. And I just wondered, in your experience, whether you had done any work on that.
I think at least I can speak for Denmark. We have a very active psychiatric system, which is going out and informing schools and parents and all kinds of places about this concept of illness. So it's completely understandable, I think, that as a parent, you're going to believe these sorts of, you know, that my child has ADHD. Well, you know, we've got a pill for that and all these sort of things. So it's very, very normal. I think, again, parents are, of course, genuinely interested in the best for their child and don't have access. So I think literature, it can be, you know, there's lots of things that people can read about. There should be people that they can meet. I meet young people and parents. When they come as a child or as a young teenager, it's because they're thinking in a different way. But I actually meet a lot of people who have been, say, 10 years or more on drugs, and they started typically as a teenager, and girls have typically been given antidepressants for something. The boys have typically been given for ADHD and stuff. But common for them all is the side effects has increased and been defined as illnesses. And by the time they come to me, they have become schizophrenic, when actually, when you go right back to where it started, it was sometimes just something as simple or as small, if you like, as failing an exam. Now, I'm not saying that doesn't feel terrible to fail the exam, but it's certainly not the reason why those kids who 10 years down the line are now schizophrenics, never finish school, etc. Tragedies. And parents actually need to know this, that there is, you know, I always say to parents when I meet them or around wherever I go, I say, give the talking, the whatever makes sense to you, a chance. When people come to me, sometimes just to ask about, well, I heard you do something different than pills. And I can see this, I get so desperate because I know that I have just maybe half a tiny little chance. And I always say, you know what, if you give me 6 months, psychiatry is waiting, but somebody, you know, but you can get caught there. Just 6 months, give it a try, or even if it's not me, something else. Yeah. But parents do want it. They don't have access to information. And I know lots of hospitals and things try and say it, but the hospital oozes medication. It's really difficult to argue against medication in the system that is just massively pushing it. Kind of best if you can meet people outside, I think. We, for example, just as another thing, we're a group of people, we hold information meetings. We find, you know, libraries and stuff, and invite people to come and discuss psychiatric drugs. You know, what's it like? We're a little group of people, and in the cafes, and just talk about what is it like to be on them? Why do you want, how to get off them? You know, is there possibilities? And that's lots and lots of people come to that. So those sort of things doesn't cost much. Just find somewhere and throw us a piece of paper around, and yeah, Facebook.
What's interesting that we're parents, I've had situations, I don't have the experience of Olga with parents as she does, but I have a few, and I can recount a couple of stories that happen. But often I would have the father and the mother would have different points of view about medication. One would be for, and the other one would be against. So there would be like a tug of war between. And so what I would do in the situation with GAM, we would bring the focus on the life, the quality of life of the child, instead of having this tug of war pro or against medication. How is the medication impacting the life of your child? So we enlarge the dialogue to look and for the person, whether it's a child or an adult, their points of view on the impact of medication in the different spheres of their lives. So this way it's concrete, and we're all working. Nobody is against quality of life. The doctor, especially the child and the parents. So that could be an interesting way to approach it.
Yeah, I've got one. Olga compared changes in attitudes to smoking and compared it to psych drugs. Do you see any of the potential of legal challenges via insurance claims and payouts to challenge the damaging impact of psych drugs on an individual and collective basis, class action?
Very, I'm praying for the day that we do win a case, that we go, many people have tried. I think, I know in the US, they've got, pay out massive fines. It's been very difficult here in Denmark, and I believe also probably in the UK. So, and we've developed, because of people unfortunately dying, we created the organization called Death in Psychiatry, which has attempted also to go the way of the courts. And even though people, have been, it's proven that it's the drugs, to get it to a court, to truly make an impact is massive. It would crack open a huge market. There's not an interest. So, but that's not to stop. People must carry on. We must carry on, because there are people who are seriously damaged by them or even do not survive it. And that is a tragedy for each and every one of those people. Yeah.
Thank you. Can I just throw a quick question in? Somebody's asking, is there any training or support available to offer help for people to come off psychiatric drugs? So training people to support other people.
We're doing that. We're beginning, but that's in Denmark. We're a group of people who are doing that. But maybe we should, now that we're getting all this online stuff, to offer that. It's actually, I'm getting a little bit into this. I've been rather against that. So I have to think a bit outside the box on that one. We've actually got a group, a self-help group. We're running it kind of like the Hearing Voices group for people who are want to get off psychiatric drugs. That's so far in Denmark, but I'm going to be part of starting up with someone else, an English-speaking one, which is online, so people, could come and be a part of that. So lots of things like that. But yes, there's a big need for people to learn about not just how to do it, but actually how to support people, because lots of people who work in psychiatry or our family members, or are quite nervous about it. So it's to talk about those sort of, especially those sort of things. And the other one, because I've spent a lot of time looking at that, is that it's illegal to prescribe drugs, but it's not to help people off drugs. We can all do it. It is completely, that's a big, huge, as I call it, the Fort Knox is breached in that sense. In fact, I'm writing a chapter on that one, but so we can all do it. Now, that doesn't mean that you shouldn't, know what you're doing. That's really also important. Yeah. So maybe, I don't know, Paul, maybe we should got your Zoom package here. Yeah,
absolutely. Yeah.
Of course.
And certainly we want to extend this discussion and debate much more widely than we can. And we've noticed all since the beginning, when we met in a cold, half abandoned theatre, and we've always filled rooms, and we know there's a lot of people out there who want information and want to know what their choices are, and also want to find positive ways to move away from relying on meds entirely, or if not at all. Celine, you want to come
I'll make it short. So GAM has 7 steps, and the last 3 steps are about reducing a withdrawal. So we teach GAM all over the place, here in Montreal, Canada. It's in different places around the world, so it's an ongoing. So we decided from the start, when we teach GAM is about choice, but we also teach about withdrawal because people don't have access to the information. And we're constantly, augmenting the information as we learn more from people who take the meds.
And do you have things with the ECT? Because you were, well, that's actually a different topic, but I think it's really important. Just want to acknowledge what you've been saying, Celine, about that, because that's also.
I think that people need to, the people need to hear other discourses beside the medical model. So they need to hear the other story. The main story of medication is the people who take it, and the story is not being heard. And ECT, it's very taboo. It's taboo to take psych meds, but it's even more taboo to have ECT because we've done a research. So we're also working on that, because when we take on ECT, what we're doing is that we're taking on the medicalization of human suffering and of the situations of the people. And so the battle is on. Yeah.
The battle is on, and
Yeah.
I'm just going to ask Celine, particularly if we could do maybe a longer workshop where you could explain about GAM and how it operates, and give us a whole session on that. I wonder if you'd be prepared to do that.
Yes. With
I heard
feisty.
her.
With feisty.
And equally, Olga, similarly, I think we need to know more about the international withdrawal, and particularly some of the very more active things. And again, I think we want to grow this movement. And I've noticed in the chats and the question and answer, we've not been able to answer hardly any of your questions, and we really apologise for that. Neil, can you make sure you capture the questions if you are able to, if there's a way of doing that? And also, I've seen that the chat has been really lively, and we're very, a lot of gratitude to you for being really positive about these kinds of opportunities, which there are too few, where we can openly discuss medication as something that is resolvable, and that there are positive, constructive ways that we can deal with this issue. I want you all to keep safe, and if any of you are on medication, that seek support and advice if you're thinking about coming off it. There's loads of resources available online. Should be more. If you go to things like the Intervoice website, we've got a whole section of videos that we found on medication, including some of the things that Celine's involved, other people involved in as well. So I think my concern is that we need to grow this as a movement, and it's not just in opposition to something, it's also providing alternatives. And you've heard today about things like open dialogue, for instance. We've touched on that. We've touched on Soteria House, but more engaging ways of being with each other in community to resolve some of these issues that are overwhelming us. And I'd also point out that quite a few of us here are also involved in the Hearing Voices movement, which is another way of actually saying these experiences need to be validated, understood, and respected as being real and meaningful, and that people don't just get to these places for no good reason. There's reasons for this, and we need to understand those reasons. So I'm sorry for the fact we've not been able to be as participative as we can. I know some of you will be quite frustrated because I've seen a lot of you raise your hands and want to be part of this discussion. We'll find a way of doing that. We're learning ourselves about how to use this platform, and we will seek to improve and enhance your ability to participate. But for now, we are what we are. And I'd just like to thank all the people in the room today, and particularly our fantastic panel and our wonderful speakers for the time and support that you've offered us. Look out for us. We're live. We will be coming back with some more events in the near future. And I think we've just raised enough money through your very generous donations for those who offered gifts to help us support this event, which will enable us to buy another package so we can keep running these events. So this is great. So I think we want to be that. We don't want any funding from medication companies, is basically our ambition. So, and that's the thing. Olga and Celine, our special guests, thank you so much for coming along. I hope you've enjoyed this, everybody. I have, certainly, and we'll see you again. Watch this space. Thank you very much. And
thank you. And can I just say, because you were saying there's lots of questions, if there is any, you just write to my email. I'll try and answer, or however you do it. I was thinking a bit sad if there's a lot of questions that never got answered to us. Could write to us.
Yeah,
maybe
I've managed to find a way of saving the chat, and I haven't got the questions.
Yeah.
So count me in too.
Yeah, that's what I was saying to both of us. I was thinking, we could send it to us and we can.
It will force us to stay connected. How's that?
I like
Yeah.
that.
Me too.
Okay, so we're kind of
Yeah.
ending the meeting, but just stay on board now so we can see if we can sort out this issue of how to save the questions and answers. And on that one, if you're
Oh, I can see the questions.
Thank you very much, and we'll see you again.
Yeah.
I
I can see some questions here.
I've saved the questions,
Yeah,
Paul.
You got the Q&As, you saved them. How did you do that?
I just copied and pasted.
Oh, well done. Right, thank you very much. Great. That's that one anxiety out. We'll share those. So there's still 64 of you around, so that's good. Noticing all of this. We'll be back. Watch this space. Thank you very much for attending, and I'm going to close the meeting now. Goodbye, everybody. Thank you so much. Brilliant day. Brilliant.
Bye.